pleasure to welcome you all to the first virtual international symposium on digital health, which follows on from our successful face-to-face meeting in Hong Kong last year. I'm Dr. Michelle Morris, an academic fellow from the University of Leeds in the UK, and a fellow of the Alan Turing Institute, the UK National Institute for Data Science and Artificial Intelligence. I've been working in health informatics now for almost 20 years, first in industry and for the last 10 years in academia, now applying a data science lens to digital health with a focus on nutrition and lifestyle analytics. I'm a founding member of the International Society for Digital Health. Along with my colleague, Dr. Esther Talboom-Camp, I'll be facilitating the webinar today.
Well, thank you, Michelle. Well, good morning to everybody, good afternoon, good evening, and good night. I am Dr. Esther Talboom, also a facilitator for session 1, and I'm joining from the Netherlands. I too warmly welcome you to this ISDH, which started in Hong Kong in 2019. I am a board member and senior researcher of the National eHealth Living Lab in the Netherlands, which is part of the University of Leiden. I have been working in healthcare for almost 30 years as a medical doctor, as a researcher, and in several leadership functions. And as Chief Innovation Officer of the large European diagnostic company Unilabs, I develop and implement digital applications with a bright and intelligent team. I always strive for the best possible and future-proof healthcare, including digital health, by stimulating cooperation between healthcare science and industry. Michelle and I will do our best to lead you through this interesting session. Michelle.
Great, thanks Esther. So before we start, I'd just like to share a few housekeeping points. So first of all, we invite everyone to submit questions to our speakers through the Q&A option at the bottom of your screen. Where there's time, we'll ask very short questions after the talks, but if not, we'll save them up to the panel discussion at the end. Secondly, please do use the chat option to network amongst yourselves. You know, send intros to each other and thoughts, ideas using everyone in the drop-down list. And then just a quick reminder that we're recording this session, and that will also record your chat and the questions along the way as well. So to get us started then, I'm delighted to welcome Professor Kelvin Tsoi to share a few words with us. So Kelvin is Associate Professor at the Jockey Club School of Public Health and Primary Care at the Chinese University of Hong Kong and President of the International Society for Digital Health. Kelvin.
Thank you, Michelle and Esther. Hello, everyone. This is our second time to organize the ISDH, the International Symposiums on Digital Health. We had our first meeting in Hong Kong last year. The experience was good to encourage interdisciplinary discussions for healthcare development. Interdisciplinary discussion means that we share our thoughts and ideas from different backgrounds of professional training. Just like the first day of my discussions with a computer scientist, Professor Simon Poon from University of Sydney, Australia in 2017. Although I'm an epidemiologist, I start to speak some engineering language now. Due to COVID-19, we cannot organize a physical meeting as planned. Therefore, we organize this webinar and hope you have a chance to share your global points of views on digital health development. Digital health is important, especially in the pandemic with COVID-19. In Hong Kong, we have a lot of discussions and planning to encourage telemedicine, remote monitoring, especially for the elderly patient care. Digital tracing for social contact among COVID-19 patients becomes a very important direction to prevent disease outbreak in such a small city with huge population like Hong Kong. Therefore, digital health, as a matter of fact, is becoming popular and will be very important in the era of high-speed computing. I do believe that this meeting with different experience sharing across the regions will offer some insight for our future moving during and after COVID-19. The last but not least, I would like to take this opportunity to thank all of the speakers and also the organizing committees. Your support gives us a driving force to further promote the development of digital health. Thank you very much.
Thank you very much, Kelvin, for your warm welcoming words. And of course, thank you very much for the organization of this virtual meeting of the ISDH. Thank you for that.
Yeah.
I want to welcome now Dr. Ashley McKimm, is Director of Partnership Development at the British Medical Journal since 2017 and Head of Innovation and Improvement at BMG as well. He practiced as a medical doctor in the UK before being seconded as a clinical advisor to the National Health Services, NHS. He is director of the International Forum of Quality and Safety in Healthcare and past chairman of the UK Medical Journalists Association. We are very happy that he's going to share with us his knowledge about the digital innovations from the COVID pandemic that will make the biggest impact on health by 2030. Thank you very much, Dr. McKimm. The floor is yours.
Thank you, Esther. And I'm looking forward to learning a lot from you guys over the next couple of days as well. So really nice to be here. Real pleasure to be here as well. And I think in starting this session, I think it's difficult not to first reflect back on the fact that I think for all of us who work in healthcare, that this has been a really tough year, probably one of the toughest years that many of us will face in our lifetimes. And as we've passed that 1.5 million recorded deaths from COVID, I think hopefully today and tomorrow, we're starting to look at some of the early progress towards a new normal 2020 with the rollout of the vaccinations and some of the innovations that have developed over the last year as well. So with some caution and not forgetting about the horrific impact of COVID-19 and the lives affected, I think I want to look a bit further forward into the future and some of the innovations from COVID that will bring hopefully a bit more positivity in 2021 and beyond. So in this session, to kind of kick off today, I'm going to take us on a look forward, quite far forward, in fact, 10 years, as we focus on the innovations that really matured over the last 9 months and those that we think will make the biggest impact on health by 2020. So just a very brief introduction that Esther very kindly gave, but I'm Director of Innovation and Improvement at the BMJ. I'm also new Editor-in-Chief of BMJ Innovations. We've been focused a lot, we're focused a lot through next year on the innovations coming out of COVID as well. So if you want to know more after today's talk, do follow us. And more importantly, if you've been responsible for digital health innovation, do check out our call for papers because we're publishing a special collection on the digital innovations that came out of COVID as well. So before I jump forward, I want to go back and away back to the first pandemic that was recorded back in 541 AD, which struck in a city called Pelusium in northern Egypt. And it was also known as the Justinianic Plague. It raged through Europe for the next 2 centuries and killed between a third and a half of all Europeans. But this pandemic and the pandemics that followed to the present day, despite all the devastation, despite all the death, despite all the destruction, they were hotbeds for innovation. And we made incremental steps forward in public health. We started with the basics of quarantine and health protection. And as the saying goes, necessity is the mother of innovation. So wars, pandemics, sustained climate change, all drive innovation. If you look back through history, things like the cholera pandemic of the mid-1800s was defined by the birth of epidemiology. The Spanish flu of the early 1900s gave us a focus on public health. It also gave us the International Bureau for Fighting Epidemics in Vienna, which was a precursor to the WHO. And as a quite quick side note, you may want there's a great paper by Mao and Pop, which looked at the evidence for whether natural disasters do spur innovation, spur technical innovations, and the short conclusion is that they do. So I thought for interest before we start, it may be just worth looking at what's been going on at our flagship journal, the BMJ, this year. We've seen a staggering 85% increase in submissions, not all of them COVID related, but I think the challenges of this year seem to have pushed forward other research as well and pushed forward other papers. And obviously published papers and completed research don't automatically translate into implemented programs or improved outcomes, but I think it's an interesting trend when we're looking at innovations today. So let's come back to COVID-19. This was the first pandemic where the rapid deployment of technology, and particularly digital technology, became a core component of how we understand, how we contain, and how we deliver a potential treatment for COVID. And I think Just the way we look back on cholera and it indicated epidemiology, we look back on the Spanish flu and the progress we made in public health. I think looking back in COVID, it's likely we'll see this as the digital health pandemic. So I think it's people working in this space, we're at a really interesting place at the moment. And, you know, I think at one point over the last year, I think every country, it seemed, had its own variation of a track and trace mobile phone app. People were zooming into doctors' consultations and healthcare shifted online wherever possible. We saw, you know, rollout of lots of AI and big data projects that pivoted to try and tackle this disease. As you'll know, many of them failed. So lots of these innovations failed, and like past global crises, many will still go on to play a permanent role in health beyond COVID-19. So I'm going to touch very briefly, given the time we've got, on four which we think will live on to play even bigger role after COVID. So the four we're going to look at very briefly are vaccines, second, telemedicine, third, AI and big data, and the fourth, which is a little bit unusual, social media and digital media. And I realize these are probably a controversial choice and you'll have your own opinions, but these are four that we are going to be focusing a little on in the journal next year. And just to say that there are much more experienced people speaking after me today in these sessions, but I hope this will be a basic introduction and hopefully prime the discussions for the rest of the symposium. Before we dive into these, I think it's worth just, keeping in the back of your mind the 5 factors which are attributed to the low impact and the slow adoption of technology, including digital technology. There's lots of different variations of this list, but these 5 that, you know, we do work in a very heavy and inefficient sector regulation in healthcare. We have a sort of big risk aversion, quite rightly, due to safety, to trialing new technologies. That we have both in the private sector and public sector payment structures that are geared more towards quantity and throughput rather than quality of care. And I think we have fears coming from both policy and management and also healthcare clinicians that technology slows us down and slows down delivery as well. And finally, I think there's always been that fear that it removes that clinician-patient relation. So these are some of the barriers that we talked about before COVID, and I think just keeping those in your mind and just thinking about what reduced or what changed during the time of COVID as well as we go forward. So first, I'm going to start with the obvious one, so vaccines. And I think if we went back 12 months ago, we'd have thought it impossible that we had one vaccine, never mind 8 viable vaccines globally. We've got, I think, way more than 30 in late development from many different types of vectors. And where we've got to is probably a decade shift in our understanding in the rapid development of vaccines through new technologies. And you'll see on the screen this graph, which was from the New York Times back in April. And it seems ridiculous now that we look at vaccines taking 10 to 15 years for vaccine development. We've compressed the timeline into such a short period through innovations at every step along the way. And if you look at even at the detail of that timeline, you'll see even the most optimistic scenario was looking at a vaccine next May. So it's pretty unbelievable that we're starting to see the first mass vaccine starting on Tuesday. And this isn't just a freak occurrence. We've seen a sort of fundamental paradigm shift in our understanding of the methods of vaccine development. The sort of Pfizer, BioNTech, mRNA vaccine is a leap forward in how we'll do the rapid development of future vaccines as well. And you can see how lucky we are compared to many of the past pandemics that we took a long time to develop vaccines for, or are still in the process of trying to do that. And I think throughout this, I'm not just talking about the clinical development of vaccines. We're here to talk about digital health. And this was fundamental, I think, at all stages in the process. We had repurposing of AI tech to model molecular interactions and examine the complex structure of the virus. It sorted through many different components to identify those that are most likely to trigger an immune response, and also those which remain stable with small mutations of this virus as well. So digital is a really key part of how we address that. And you can see lots of different elements across the entire spectrum of how digital health helped with each of those different points. And I was hearing on Tuesday about also how we're using that digital modeling, machine learning in our UK schedule. So we're deciding how we're going to vaccinate the population, the different segments that get vaccinated in different orders. And there's a huge amount of data crunching that goes into deciding who gets vaccinated first, the people who are at most risk of dying from COVID versus those that are at most risk of transmitting the disease. So digital technologies are being applied at all different steps. We've also just procured a company called Genpack, which is using AI to constantly monitor the adverse reactions from COVID as it gets rolled out next week as well. And we haven't even started talking about the distribution logistics, hugely powered by AI and big data. And if anybody's of interest, we're publishing a paper we're coming up on Vaccines 4.0, which is covering some of those things that we're trying to address today. You probably just heard that Pfizer has had to reduce the number of vaccines it's rolling out by a half because of logistical problems. And a lot of that comes down to supply chains and managing that. And that all comes down to digital technology that's been applied to health. So lots of positive developments there. Some key challenges we need to address as well. I think that we're already seeing inequalities in vaccine access and the types. We're seeing the most efficacious vaccines being limited to certain countries, certain high-income countries. And we're also seeing certain countries, despite having agreed to vaccine neutrality, adopting a me-first approach as well. So that's one of the big challenges we're going to face. We're also seeing, I think, affecting us, we're seeing lots of issues around IP. This has been a very mishmash of public funding, private sector as well, and where the IP sits around this. And one critical challenge is the anti-vax movement and the public trust in vaccines, which is going to be essential if we want this program to be effective. And as you say, it's not just the anti-vaxxers, but the wait and seers, the ones who volunteer initially for a vaccine, or the ones who won't volunteer initially for a vaccine. But it's critical for us to achieve herd immunity. And we're going to come on to that a bit later on whenever we talk about sort of digital media and social media as well. So the second big shift that we saw during COVID was this shift to telemedicine, virtual medicine. And I think for all of us, we know that primary care and outpatient hospital care have long held that promise that they could be delivered largely digitally. But COVID precipitated this, and many countries adopted this as a digital first strategy. So if you take here in the UK, going back to December of last year, just 15% of our 23 million primary care appointments took place by phone or online. After COVID hit, this soared up to half of all appointments. And if you take England and you take the majority of primary care practices, 90% are now able to run their practice virtually and do most of their consultations as well. So that's a huge shift that we've seen over the last year. And it's a paper we published around the reasons for this, and it's three sort of very simple, common sense reasons that we've adapted technology, we've adapted software that already existed. We haven't started from scratch. We've realized during COVID that having something that wasn't perfect was better than nothing at all. Secondly, many countries have relaxed privacy and data regulations for video. So we've been able to take advantage of those. And the third thing is that we were pushed into this, that governments, including the UK, required that any care that could be done without physical interaction must be provided through remote consultation. So those three things help to shift us along. And we shouldn't forget about the fact that actually there was, low and middle income countries, although device and connectivity challenges meant we didn't see that jump to video, there was significant innovations that will stick around past COVID as well. So one of the big things we did see was adoption of low-cost open access platforms for COVID reporting, analysis, tracking, but also things like SMS became key. Not just outbound public health messaging, but two-way management of health concerns. Lots of small digital startups that came around. In Nigeria, we had a sort of pivot from a customer service startup that went into using AI algorithms for two-way SMS and call management. So they managed track and trace and case identification in Nigeria, but also give two-way advice. So people are able to ask questions around both health misinformation, but advice for managing their personal symptoms for COVID as well. So challenges around telemedicine and virtual healthcare. I think that, again, mostly around inequalities. High-income countries, that's primarily elderly, disabled individuals without access to, smartphones, smart devices. Low-income countries, that's much, much broader. We also, I think, we haven't had payment structures. If you look at the US, for example, telemedicine and physical consultations didn't have parity in payment. So only about a fifth of US states give payment parity to telemedicine and digital health versus in-person services, which really didn't help the adoption there. Data security and privacy, another key issue. Some of that was relaxed. I think the public generally became more open to the fact that they had to share information. This was, they didn't have a choice to avoid this, to go and see their doctor. And I think finally, that we know there's limited knowledge, limited evidence around the effectiveness. There's very few comparative studies into tele versus real medicine. And I think we desperately need that. We desperately need the comparative evidence to justify this shift. And the work from COVID isn't exactly reproducible, but I think that's the next step, that we're going to start to see where telemedicine, virtual health can make things more efficient, more effective, and certain areas that it can be really effective in as well. So let's move on to the third topic. So third is AI and the role of big data, and we've touched on this already to a certain extent. This was already rapidly evolving, but it accelerated, and you'll have noticed multiple pivots happening during COVID as well. Just to touch on a couple of examples, this is Blue Dot. It's a really great Toronto startup that I visited. This is their office. I visited them last year, and they were credited with being the first to recognize the unusual cluster of pneumonia cases in Wuhan before the official sources came out. So they used AI algorithms to scour foreign language news, reports, animal disease networks, and they alerted us about COVID back in December 31st, as did another firm, Data Miner, on the same day. And then Blue Dot went on to predict 10 of the 12 first cities to be impacted using their AI algorithms. And they're still going, they're mapping 200 infectious diseases in real time as we speak. Many AI companies tried to apply their tech. So many people pivoted to apply their tech to COVID. Quite a few worked on diagnoses and better understanding. Many, such as HERE, aim to differentiate COVID from other respiratory diseases. There was a rapid transition into the space by AI companies from across healthcare. Lots of companies that came in and did everything from using AI to look at treatments. We had in silico medicine from Hong Kong that used AI to run through lots of different molecules in treating COVID. We had the many attempts of using digital track and trace, the number of apps that we had developed with Bluetooth, trying to pinpoint hotspots and shape public messaging. I'm not going to go into that. That's a whole presentation in itself about the learning of what went wrong and what failed and what didn't work. But lots of challenges, I think, here. I think there's been a greater acceptance of the use of data. I think, and we'll talk about this at the end, that are we going to go back into that space where privacy concerns often inhibit innovation and slow us down? There's obviously a balance to reach between those as well. We had a rapid transition of AI technologies from outside healthcare. So we had a lot of investment that flew into startups, and digital health has been a sector that has had underinvestment in the VC space and has been seen as being prime for disruption. And the question is, will we see after this a renewed investment in startups and in digital health for disruption in healthcare? Now we've come over some of these barriers that we did during COVID. And finally, I think AI in a clinical setting is still a lot of issues. We need to do a lot more studies, a lot more evidence. There's lots of safety issues, particularly when it comes to clinical decision making. And we have the difficult task of putting in safeguards. And I think that's one of the key challenges for the next 5 to 10 years, is putting in the safeguards to make sure that using AI can be safe as well as being effective. So finally, just very quickly to run through social media. This is a bit of a strange one to pick out, but in terms of digital health innovation, I think that COVID accelerated to some key regulatory and purpose-based discussions about social media. Usage soared, so it soared, a third to 2/3 increase, and it wasn't just more time spent in social media; it was a lot more content being created as well. And COVID was a story really of two halves. there were rare examples of real excellence in communicating public health. And I may try and play this, but it may not work. I'm sure some of you have seen this already, but this was the one of the, I think, the showcase examples of social media during COVID. It was by the Vietnamese Ministry of Health, who partnered up with pop stars very early on in the outbreak and created this video to teach people about prevention, hand washing, distance keeping. And it went viral both in Vietnam and elsewhere, spawned lots of kids, young people to create videos for TikTok. It was copied in Bangkok, Philippines, Singapore. Really, really effective. It was a collaboration that worked really well. And they're now doing a full impact study into behavior change as well. So social media can be used for lots of positive things. But one of the challenges we kind of saw during COVID was that there's a lot of fake news and a lot of misinformation as well. We got better at finding that. So there was a 900% increase in how we discovered misinformation and fake news. But it became more difficult to spot. One of the big transitions that happened during COVID was that we had a shift from social media, which was almost complete untruths before. So there's been lots of untruths published in social media about lots of different things. But in COVID, we saw a shift mainly to reconfigured information. So this was stuff that was a mix of truths and untruths, a lot more difficult to spot, a lot more difficult for AI algorithms that have been developed to spot this, to pick it up. The other big change that we had was that public figures, if you take health misinformation, public figures, celebrities, presidents of certain countries, although they accounted for a small amount of misinformation, were responsible for a huge amount of that social media engagement. So 70% of social media engagement of misinformation was attributed to just that 20% as well. And social media companies really struggled. But what I think is important is that the COVID pandemic really has brought about some fundamental changes in the social media space as well. I'm not going to go into this slide because we're a bit short of time, but it also shows that we can't address this in one way. There's lots of different social media platforms, lots of different concerns in different parts of the world. We often shift, if we try and close down something, we'll shift on to messaging and elsewhere as well. So there are challenges there. There has been a waking up of governments to and regulatory authorities to the understanding that unless they engage in social media and managing information, it can do significant harm. And I think this crisis has been a test case for people like the EU. The EU have moved quite far in how they're laying out that social media companies have to deal with disinformation. And just today, Facebook announced that it would remove false vaccination claims going forward. So they've made a blanket policy, which they did this afternoon. So I'm going to very quickly, in the interest of time, just fly through the next couple of slides. We've covered the challenges already. Challenges around social media really is that balance between freedom of speech versus industry regulation. I think the big change we're going to see over the next sort of 5 to 10 years is better use by governments and public health bodies in how we leverage social media, and also how we manage the health influencers we have as well. So that's a very quick, high-level, super high-level view of those 4 areas. I want to very quickly reflect on where we might be by 2030 and beyond, and sort of bear in mind that the evidence that has been shown making predictions like this is very uncertain. So you're more than welcome to make up your own predictions of where we end up. For vaccines, I cannot stress again how unbelievable it is where we are with vaccines, with the caveat that it does actually work, and we're still figuring out whether that is actually the case. The advances in mRNA vaccines, combined with the Google DeepMind leap forward we saw from last week about protein folding, at the very least mean that we should have a dramatically quicker process with future vaccines. And at the most optimistic, I think we might be able to solve one of those diseases from the slide earlier, which we're still waiting on, possibly something even like malaria. Either way, we're going to, I think, have advances that will save hundreds, if not millions, of lives going forward. On digital health, we're taking I think we're lacking a lot of evidence on video consultations and the impact. And I think what we'll see is that the efficacy is not shown to be as good, but efficiency will win out. I think people are going to start to drift back to in-person consultations, but some will stick with primary care and routine care. But I think people have become more comfortable with digital devices for health, whether that's Zoom calls or track and trace. And I think we'll see more innovations in this sector. I suspect we'll see a bigger shift in low-income countries, be hugely more dramatic. We've already seen during COVID accelerated rollout of low-cost digital devices in the clinical space, and we'll see more clinical decision support tools, more frugal digital health technologies, which will flow back into high-income countries. AI and big data already hugely accelerating before COVID. We're going to see really exciting things here over the next couple of years. I touched on Google DeepMind's discovery already, but key to these advances are policies around data sharing and privacy, and I think there's a lot of political will to move forward in that. I think inter-country sharing of health data is critical, and to do that we need a global body, I think, to set up some guidance and set standards, and I know some people are looking at it already. The EU is taking some big steps into that. And finally, I think social media, we're just entering, I think, an important period for social media and COVID. Health misinformation has, I think, is going to be such a big issue over the next 6 months, particularly around sort of the vaccine space. The big social media players are bringing in AI to track this. I think governments need to get on board. You've probably heard that, you know, even in the US, half of the population are reluctant to get vaccinated as well. So I think in the longer term, it's inevitable we're going to see a regulated system, particularly driven by health misinformation. So I think that's it. I think, Michelle, sorry, I'm probably over time already, but I think with some caution, and I think forgetting about the horrific impact of COVID and the lives it's affected, I'm hoping that we can sort of look forward to 2021, and we'll see lots of big innovations coming out of digital space next year. My hope is that you'll be part of this by sharing your thoughts both today and tomorrow. Hopefully, ideally publishing your work. We'd love to see your work, and hopefully doing your bit to champion the world, which hopefully will be a little bit more positive on the back of what's been a really, really tough year. So thank you.
Fantastic. Thank you, Dr. Ashton McKimm. There's some great questions in the chat, but we are going to move on to our next speaker and come back to those later. So now it's my pleasure to welcome Professor Björn Schuller. Brilliant, Björn's now sharing his screen. So Björn Schuller is a scientist of electrical engineering, information technology and computer science, as well as an entrepreneur. He's a professor of artificial intelligence at Imperial College London and holds the chair of embedded intelligence for healthcare and wellbeing at the University of Augsburg in Germany. Schuller was elected president of the Association for Advancement of Effective Computing and the International Association for Effective Computing, registered as a charity in the UK. He is co-founder and was editor-in-chief of IEEE Transactions on Effective Computing and general chair of the IEEE AC 2019. His research interests include machine intelligence, signal processing, with a focus on audio, effective computing and health informatics. Schuller is the initiator and annual main organizer of the science competitions Interspeech, Computational Paralinguistics Challenge since 2019, and Audio Visual Emotion Challenge since 2011 in the field of computer perception. So over to you, Björn.
Thanks a lot, and over to mobile digital health for COVID-19. So we have heard a lot by Ashley already about AI and its power unleashed during these days. And this one will be particularly dedicated to the idea of how can mobile health, so healthcare with AI in our everyday lives, help in this situation. The subtitle here is Ready, Set, Go. So meaning that basically we're pretty ready with this tech. The question is, are we fast enough to get it out there before the vaccine, thankfully, hopefully, stops the current situation anyhow. So what is the idea? We want to do diagnosis, first of all, on your wrist, in your pocket, for example, meaning that we're using the sensor signals that you have on your smartwatch, on your smartphone. This has been done in a lot of related use cases before COVID-19, such as depression monitoring, cold as a similar phenomenon, but also autism, Parkinson onset, Alzheimer's, and many other things. So the efforts of the last months went into getting this ready for COVID. Then, of course, we have information provision. You can imagine your Siri or whatever, and that is effect, of course, already give you information on your wrist, for example, by natural language queries feeding back to you. More interesting, maybe also monitoring of social distancing and effects. So the technology of effective computing provides the possibility to monitor well-being, like sadness, anxiety, and effects of social distancing. Monitoring of spread, that is of course big data, and we will be hearing about audio in particular and also heart rate monitoring, but audio, for example, could even be used, if you think of it, for telephone line based monitoring of spread. So if people would agree to this, it could mean that we get from voice a pre-diagnosis of COVID-19 symptoms and monitor via phone lines usage, outbreak hotspots. Yeah, monitoring of treatment and recovery includes the idea of monitoring patients with digital health tools and mobile health tools. For example, we will be seeing the monitoring of severity of COVID-19 patients. Yeah, and risk assessment will, for example, include things such as recognizing that people are not wearing their facial mask, are too close to each other, and the likes by AI. I picked two examples for you today to showcase these ideas in a digital health setting. As said, one is audio. The other one is going to be heart rate. But I really focus on audio. And audio allows to recognize a lot of things that are quite relevant. As said, cold, for example, then lung sounds, but also sleepiness, pain. So a lot of symptom-related things could already be recognized before the pandemic broke out. In particular, from sound, we can hear coughing and discriminate different types of coughing. But we can also localize, diarize, and measure proximity between speakers, for example. So that is in the social distancing setting. We can recognize as sadness, anxiety, depression, and the like. So monitor from audio effects. In particular, we ran a challenge since 12 years where we invited the community to see what we can recognize from audio. And without going into details here, you can see that most of these tasks can be solved independent of the subject. So for a whole new subject from their voice, for example, or from their coughing sounds in the case of COVID-19. But usually we're, of course, not quite at 100% for recognition of these things. Raising the question, how useful is it if we have something that is not as good as, let's say, 100% reliable test, but that is very easy to spread, comes at almost no cost, works from a distance. So this is a trade-off consideration to be made here. Now, in particular, we introduced an app recently as a concept that is ready to be deployed in theory, not actually ready to be deployed because that takes development work, but in theory, ready to be deployed means that it is running on one specific smartphone type already. It's running embedded on device, meaning your data does not go to some server, it's really locally for yourself. And what you have to do is speak into it, and it gives you a voice-based assessment if you're COVID-19 positive or not. Now, this is one approach in the community of audio analysis. There is another approach run, for example, by MIT and other colleagues, looking into cough sounds, or Cambridge does this too, to diagnose COVID-19. Now, what is quite striking is that in the papers out there already, the accuracies reported are very high, actually. So we ourselves reported 82% for a two-way diagnosis, but the colleagues sometimes went up as high as 85% or even 95+%. And that was MIT from coughing, going as far as saying that they could recognize it even if you're asymptomatic. Well, my experience has it that once you go into the wild, these numbers tend to break down, but still it seems that it's a very promising avenue to follow. In particular, in Germany, this has made a very big media wave at this moment and has shown quite some public interest. Can we use such technology until the vaccine is fully there, for example, to ease lockdown if you can have this as a very fast and rapid pre-screening tool, let's say at airports or at big events, to decide who needs a more thorough testing. That is currently an ongoing discussion. Yeah, things that you can also assess is, for example, the severity. Here we had data from Wuhan in China at the earlier days of the outbreak, and we were looking into the severity. So how severe were the symptoms? How severe did the MDs judge the COVID effect had on the patients? Here we had a 3-way task, which means 33% would be the chance level, reported at 68% accuracy. So again, we're not at 100%, but we're also very far from chance level with this. And as said, looking into well-being, for example, here COVID-19 patients in China, sleep quality, fatigue, and anxiety monitored from their voice. Again, 33% would be chance level, and again, at least for some of them, sleep quality were clearly above that, but also clearly below 100%. Now, the question that often arises then is this really covered, or are you just recognizing that somebody is a patient or sick? So the most exciting question to discriminate against, of course, is other respiratory system infections, such as influenza and cold. And you may remember from the early days of the outbreak that most magazines featured these histograms, where you could, as a layman, assess for yourself, am I COVID or am I influenza or cold, based on your symptoms, frequency of occurrence. For example, is your nose congested? Then it's probably rather cold. Are you having breathing difficulties? Then it's probably rather COVID, and so on and so forth. It's not only about the frequency, but it's also about the onset gradient. So for COVID-19, these symptoms are said to go slowly. By now we know for more things, such of course as change of personality to some point, or your behavior, and more higher level symptoms that can take place. So a lot to be monitored automatically, potentially, which a GP can't do. He has maybe 7 minutes on average for you around the world, but your AI could do. So if you have it on your wrist, on your smartwatch, if you have it in your pocket, it can listen to you, it can sense your temperature and the likes, and collect all this data over a night, over maybe 2-3 days even, and get then a much sharper picture on COVID-19 diagnosis than you would just get from a single coughing analyzed by AI or a few words analyzed by AI. So this is an example of an app my company put together in Germany, while we're listening into you symptoms overnight, for example, and then give you a feedback. How long during the night did you cough? How long did you sneeze? What's important here, of course, is AI needs data, and we say that everybody needs to donate, then only we can get a really good working system. So there's an integrated donation mechanism where the AI identifies the most important samples for it and asks you after your usage for 5 samples to be donated. Now, the symptoms at the beginning of or at launch time were recognized correctly at 83%. And as media waves spread the word and more data came in, slowly increasing on this. Now, I said I wanted to also mention heart rate as another example of something wrist-worn. We were in the lucky position that we already had a big project out there, the Radar CNS project, with some thousands of enrolled participants in the UK for a depression, MS, and epilepsy study. And what happened is, of course, that many, unfortunately, of those were later on diagnosed with COVID-19. So we had a lot of heart rate data because we already had those enrolled, coming also from such later on diagnosed with COVID-19. And we had the whole development of changes until the moment in time when we had the diagnosis. What you're seeing here is a deep neural network that has learned to predict COVID-19 from changes in heart rate. And while I will not put it on the slide, because it's still about to be put into preprint phase, the paper reporting this, I can say that it's extremely high So almost too good to be true again, the kind of success rate that we got here to predict COVID-19. So if you put these ideas together, what it gives you is that already with the sensors that are available on many watches or phones, you can do individually by each of these sensors an apparently shockingly good assessment. The question now to be answered, of course, is how good can we really get, in particular if you put these together. There's a couple of challenges, and the most pressing one is time. Will we be able to unroll this before vaccine and summer stops the most shocking horrors? Of course, we have a lot of ethical, legal, societal impact worries. We need to collect more data with patients, and then we need to be able to process data in the real world. And we need these devices or ideas to be trustable, because otherwise they won't be used. I'll just quickly skim over these to tell you that green machine learning has made huge progress. We're able to prune and squeeze networks down by 95% in size, so we can run these algorithms really on smartwatches. We were able to do emotion recognition entirely on your smartwatch from the voice. We can use this now for COVID-19 on your smartwatch. Federated learning gives us the ability to do not share your data, but just your local AI changes. So the neural network parameter changes are shared back to everybody such that everybody can get improved models. And that works very well. So you don't need to share your original data necessarily. Question then is, can we also protect your privacy from AI if you can sense it from the voice already? And we're having a whole new branch of research popping up these days to protect you from AI sensing your health state by fooling that AI by so-called adversarial attacks. Now, this is just a little advertisement also for a journal, special issues here in Frontiers in Digital Health and IEEE JSTSP COVID-19 open course if you're interested in this. And I want to end on the note that this looks really, really promising, but in particular, as we're talking about sustainability and beyond COVID-19, my real hope is, even if we don't make it in time now, we have had a good pressure in the field to ready other solutions for depression and so on and so forth, even if we can't make it for COVID now. Thank you very much.
Well, thank you very much, Professor Björn Schuller, for sharing your knowledge about this well, amazing mHealth innovation. Thank you so much. But we have to continue again. There are a lot of questions and compliments for your presentation, but we'll discuss that at the panel discussion. So thank you. So welcome to Professor Anthony Smith. If you can share your screen, I can introduce you, Professor Anthony Smith from Australia. Anthony Smith is the director of the University of Queensland Centre for Online Health and also adjunct professor of digital health and telehealth in Denmark. He has around 20 years of experience with research, mainly focused on the planning, implementation and evaluation of new telehealth application for patients and clinicians. And he's also the scientific committee chair for the International Conference on Success and Failures in Telehealth and former president of the Australian Telehealth Society. And he's going to share his knowledge with us about Australia's telehealth response on COVID-19. Please, Professor Anthony Smith.
Thank you, Esther, and good morning, afternoon, evening to everyone who's joined online today. It's a real pleasure to be involved. I'd like to just begin by acknowledging our traditional owners in Australia of the country and paying my respects to our elders past, present and emerging in Australia. So my role is Director of the Centre for Online Health at the University of Queensland, and I've been involved in telehealth for over 20 years. So when a few people during COVID came up to me and said, "Oh, have you heard of this thing called telehealth?" I was able to actually kind of politely say, actually, it's not that new. It's been around for quite a while. So in the next 10 or 15 minutes, I'd like to kind of take a practical angle to telehealth by giving you some examples of how telehealth is done, but also alluding to some of the papers we've published, which will mainly give people a probably more practical view on what needs to happen next. So we've seen a tremendous reaction to COVID, despite the sad situation and the tragedy that's resulted, similar to what Ashley was alluding to. We've also seen some miraculous changes happen in the health system. And I think one of the underlying things that I think we need to watch internationally is how do we embrace that change and how do we maximize the use of digital health. So my work is primarily going to focus on telehealth, and telehealth makes sense obviously in a country like Australia, which is extremely large in terms of distances that people have to travel, and most of our services happen to be along the coastline or in the major cities. So naturally it makes sense to do telemedicine. From a patient perspective, and particularly if you think of things like pediatrics, you know, traveling 300 or 400 kilometres or a couple of thousand kilometres is not unusual if you have to attend a specialist appointment. So that will give you some context about why telehealth obviously has an important place in Australia. But I'll also address another important change in our thinking of telemedicine, is that it's not just about distance anymore. Telemedicine and telehealth is about supporting everybody irrespective of where they happen to live. And that's been a very important realisation, particularly during COVID. Huge country, and this just highlights in terms of some of our friends who are connected on today, how big the country is. And we do have people dispersed in very small populations around the place. In terms of defining what I'm talking about, telehealth has lots of different definitions, and we've already heard lots of different terms under a broader umbrella of digital health. But I'm basically referring to any form of communication technology which is used to deliver a health service across a distance. And the ones that I'll give you examples, I'll particularly focus on real-time or video consultation, or perhaps store and forward. Also includes things like remote monitoring. But the point I was making before is that telehealth used to be seen as something to help people in distant locations. Whilst that is true, telehealth is equally important for people who may only live a few kilometres away from the main hospital, because they may have difficulty accessing that specialist appointment. So what's driving telehealth? We've mentioned a few things already in this seminar, but obviously there's an increasing demand on healthcare. We need to get smarter in the way that we provide our healthcare services. Ageing, we're looking at chronic illness, increasing costs of services. We're seeing other industry players escalate their use of digital techniques very, very quickly and very efficiently. For example, online banking and shopping. And the healthcare sector has been somewhat slow with the uptake. So it's been a little bit, you know, a little bit sluggish, and that hopefully will change, particularly during the pandemic period. I've talked about the access issues already, but the screaming elephant in the room at the moment obviously is the pandemic. So the pandemic, from my own view and my own perspective, has really made telehealth a household name. People now know what it is due to necessity. People have experienced telehealth either through a telephone or a video consultation. And now people, I hope, will start expecting this type of service in the future. This will show you what's happening in the context of COVID. Our government has reacted with a number of different universal strategies and also some statewide strategies. But fortunately, from an Australian perspective, we're in a pretty good position in terms of our control of COVID, certainly in comparison to some other countries, which unfortunately are still struggling. We've done that through a number of different ways, and this talk's not about the different governmental strategies, but obviously strategies employed around the world around social distancing. Funny enough, telehealth assists with social distancing, so that's what we should be doing. We've had normal restrictions in terms of restricting travel, encouraging people where they can work from home. We've had our schooling system for a few months restricted. But the most important thing is, from a healthcare perspective, we've seen a massive growth in telehealth activity, both from a public and a private perspective. So I'd like to introduce some work that my team at the Centre for Online Health is doing, and our centre has been in existence for about 22 years now. So it's an important team which has a particular focus on not only doing interesting research in telehealth, but we also are quite unique in the sense that we also provide teaching and training to not only clinicians, but other students at the university and other universities. And we also provide consultancy services and also telehealth services. So we're a research group that actually gets our hands dirty, and we actually work with clinicians. I have a team of about 25 staff now who do an incredible job in all different aspects of their work. They all bring different skills to the table, many of which have clinical backgrounds, technical, research, academic, educational backgrounds, and engineering. So lots of different skill sets that I've brought into the team that are able to kind of help deliver on many of the projects that we facilitate. The services we run is for a major hospital in Brisbane, and with the services we've run to date, we've conducted over 70,000 telehealth consultations. And from an academic perspective, in terms of number of publications around the world, we're currently ranked #1 as an organisation. So there's lots of different services that we offer. The other thing that we like to refer to ourselves, because we have a very practical view of telehealth, and we don't go developing technology, we essentially try to use what's available off the shelf. But because of our practical kind of view, we call ourselves pracademics rather than academics. But the good thing about it is that we are always engaged with clinicians. We do a lot of travel, we work with health services. And I think one of the #1 challenges in ensuring that telehealth is here to stay is thinking about sustainability and how do you actually build that into the health system. It's not essentially just about the technology. It's more about how do you change practice and how do you assist clinicians with a different way of working. And I think that's one of our major challenges. Previous work I've done in the area of paediatrics was an extensive program. We've just published a paper summarising 15 years of work. And in all of these slides too, I've referenced some of our publications. And if anyone would like a copy, please let me know. And I'm more than happy to make them available to the delegates. As part of our telepediatric work, we conducted over 20,000 consultations for 37 different clinical specialties in lots of different areas around the state. So there are lots of different services, and our model was really fitted around a centralised coordination angle. So our view there was to make telehealth so easy in the system to do that clinicians and that, just couldn't refuse it. So we provided a lot of coordination and support from the point of the referral to the consultation to the completion. Since then, lots of different clinical services have really resulted from the centre in partnership with major health services around the country, in particular Queensland Health, and also some of our community-controlled Aboriginal health services. This is the model we use in our major hospital at the PA, the Princess Alexandra Hospital. And you can see here, we've got a model where a centralised team is responsible for a number of functions, and those functions are important things that need to be done behind the scenes to help facilitate telehealth. When done well, you can branch that out and certainly make it a much more effective process where you can bring in multiple specialties. What have we done since we started this major service? Well, and since 2012, we had a few different services that were on offer. This will just give you an indication by list. You don't need to read the list, but it'll demonstrate that how our teams are integrating with clinical services and making telehealth work in a whole range of different areas. There's no one magic model that suits all. Every single service is quite unique, and that's a very important way of applying a health service and looking at the various procedures that are needed, is to make sure we understand the needs of each of those areas. To give you an idea of growth of activity, certainly a huge reaction. And as people have alluded to already, there's been an increase in telehealth activity around the world, and yes, there has. In our hospital, we did 450 consults in our first year of operation, did about 6,000 last year. This year, we've just passed 30,000. So major changes. In this paper, we first wrote when COVID really became very prominent early in the year, around February. This paper really just highlights the fact that, of course, telehealth is going to be important in a situation where social distancing is important. It not only is a valuable way of keeping our clinicians safe, but also obviously a valuable way of keeping our patients safe. So the question is, in the absence of a pandemic, what do? We don't switch telehealth off. If anything, we should be encouraging the ongoing development of telehealth to make sure that it is a routine service offered in our health system. So in the unfortunate event of another pandemic, we can increase the proportion of work done virtually and not have to try to build services from scratch. As part of monitoring what happens in Australia, and one of the ideas of my presentation today was to describe impacts. Now, obviously, a large amount of work is now being done virtually instead of in person, and that's obviously to follow the social distancing regulations. But you can see here a massive increase in the amount of work that's happening by telemedicine. I'll point out one thing, though, is that most of the work is actually being done by telephone conference, not video conference. And this is an area that we're exploring at the moment and trying to encourage greater use of video conferencing because of the added benefit of being able to visualise the patient. So there's still work happening in this area and debate about how you fund particular services and which services should be provided either by phone or by video conference. To show you the impact again from a total number, Pre-COVID, we did about 270,000 consultations. Since March, we've done over 32 million registered consultations on telehealth. So massive, massive increases. And I'll just point out again that the most of this work is done by telephone. We'd like to see a lot more done by video. But the general practitioners, particularly in primary care, are mainly using phone to connect up with their patients. On our website, we've been monitoring this, and I encourage other countries and jurisdictions to do the same. It's really good to get an idea of what activity is happening in a range of different areas. And this information is data which is reliant on the national Medicare information. So it shows you number of services and cost. So in the point of view of general practitioners, you can see that the onset of COVID has resulted in a reduction in the number of face-to-face appointments, but a massive spike in the number of telephone meetings, and not really an impressive increase in the number of video consultations. And these slides are available on our website, and we keep them up to date every month. So we followed it up for a range of different specialties, including specialist consults and also allied health consultations. Lots of different barriers and enablers, and these are well reported now. So certainly from my own journal's perspective, we've seen enough in terms of what people perceive as barriers and enablers. The barriers are simply not just the technology, the human resources and the ability to do effective change management in an organisation is very, very important. We are seeing increasing evidence for effectiveness, but I think we're lacking some information about how to make services sustainable, not only which models work and which ones don't, but why don't they work and why do they work. So that's some of the factors that we need to do. Research and evaluation, of course, is very important. And I say that sincerely from my own perspective in a research department, but without the evidence, it's very important to convince government agencies to invest in these alternative options. So the other thing that we've done, which may be helpful for everyone who's developing telehealth, is a quick reaction to the sudden interest and need to do telehealth meant a lot of questions. So we actually examined a lot of the Twitter conversations around telehealth, and our team have actually put together some quick guides. And these quick guides provide very simple information and very easy to use guides, which are downloadable in PDF format. So all of these are available by our website, and I can certainly assist people and provide links later. A more recent paper that we've published is addressing the question about what next. So I think this is very important to start thinking about the pandemic. The pandemic will be resolved, and what do we do next? So this just identifies some very important things that we believe need to be focused on from not only a government but a health service agency perspective. We need to make sure we develop a skilled workforce. There's no point expecting our clinicians to work in a certain way if they've never been trained. So training not only in our existing workforce but our next generation needs to be done. We need to empower consumers. People all of a sudden know about telehealth, so consumers need to have the power to go in and ask or have the option to do telehealth. We need to make sure that every service, every new service has remuneration attached to it, and that the remuneration is appropriate. We need to make sure our entire digital ecosystem is ready and fit for telehealth to support it. We still see problems today with issues around online scripts, referral processes, scheduling processes, and also compatibility with different software systems. And I think one of the underlying things is that telehealth needs to be considered just routine business as usual practice. It's time to move on. It's time to stop thinking about telehealth as a nice thing to do and something that we do during a pandemic. Telehealth should be something that we do all the time and offer it to all patients in a lot of different contexts. So just to finish off, where to from here? We need to kind of critically think about how we do our work. We need to think about where telehealth fits in from an outpatient perspective, how we visit sites and provide outreach, looking at clinical placements, and also looking at emergency advice and support for remote hospitals. The key here is to think about sustainability now. Let's focus on our new models of care and finding the evidence for those new models of care, and let's invest some time into change management. So just in conclusion, telehealth is a disruptive process. I like to say that because it's forcing us to stop for a minute and actually think about the way we provide services. Are we providing services in the best possible way? The other important thing is that we're transforming healthcare, and this is a completely new way of working, and we need to embrace that. Whilst telehealth is complex, there isn't a magic box that you can put on a shelf and solve every health system problem. Whilst it's complex, we've been able to demonstrate that with the right systems and support in place, it can be done very effectively. What I like about it is the opportunity here is to create a very efficient health service. But the other important thing is, let's bring this back to the patients, is that telehealth is providing a much more patient-centric service. So just in terms of additional information for those who would like additional information, certainly our website is the best portal to initially go to. We have the Journal of Telemedicine, Telecare, which I operate, which has a lot of information, obviously, about telehealth and its applications. And we also run an international conference on successes and failures in telehealth. So we dare you to get up and talk about not only the good things, but we dare you to talk about the failures as well, because I believe that by sharing failures and helping people reduce the risk of jumping in the same hole is just as valuable as learning about those things that work well. So thank you very much for the opportunity to present, and I look forward to the panel discussion.
That's brilliant. Thank you ever so much, Professor Anthony Smith. Yeah, lots of questions for you as well, so we will come back to those. And now, in the interest of time, I'm going to go straight on and welcome our next speaker, who is Professor Jonathan Chen. So while Professor Chen shares his screen, I will do some introduction. So Jonathan Chen, MD, PhD, is a physician scientist with professional software development training in skills in graduate computer science. He continues to practice internal medicine for the concrete rewards of caring for real people, and to inspire his research focus on mining clinical data sources to inform medical decision making. Chen co-founded a company to translate his computer science graduate work into an expert system to solve organic chemistry problems, with applications from drug discovery to a practical education tool distributed to students across the world. To gain first-hand perspective in tackling the greater societal problems in healthcare, he completed medical training in internal medicine and a VA research fellowship in medical informatics. He has published influential work in venues including the New England Journal of Medicine, JAMA, and JAMA Internal Medicine. So, Professor Chen.
Great, thanks so much for that kind introduction, and also to the organizers and the panelists. A great setup with telemedicine, and just really thinking about all the potential for digital systems to improve healthcare. You know, we're talking about in the context of course, the COVID pandemic, but realize that really the pandemic just serves to highlight many just foundational structural issues in the modern healthcare system that existed long before and that are going to continue to exist and actually are only going to continue to get worse and escalate even after we make it through the current situation. But just for an example context, think about, I saw a patient in clinic not that long ago. There's a young woman came in, she said her palpitations, her heart was racing, and she thinks she had some kind of hormone problem. I did an evaluation and I found indeed she has hyperthyroidism. She has a hormone problem. No problem. I am going to refer you to see a hormone specialist. They'll take care of the complete diagnosis and appropriate treatments. Eventually she did do that, but next available appointment will be 3 months from now. Oh, that is crazy. I mean, my patient can't wait that long for appropriate diagnosis and treatment. And mind you, this isn't you know, a rural town in the middle of nowhere or something. This isn't an impoverished, you know, Medicaid patient. This is a commercially insured patient in the middle of Stanford. But that's kind of the state of the world right now, and will only escalate over time, because ultimately the scarcest healthcare resource is access to a human expert. In the US alone, there's already tens of millions of people with deficient access, let alone worldwide, it's billions. Because ultimately you can manufacture goods, but you can't manufacture people, the goods, the people who actually know what to do with it. So a great setup with the prior discussion, what I'd like to imagine more, what if there could be multiple tiers of access to medical consultation support? You know, sometimes when you need to see somebody in person, there's no other way. Like if you need surgery, like there's no point in giving me advice. You just need to see a surgeon to start through the cutting. Maybe a telehealth visit could be good enough to get that advice. Maybe an electronic consultation. If I could just email somebody for advice on what to do, that would be enough for me to take care of it for you. Or what I want to imagine building towards is how much could we get towards a fully automated guides, data-driven systems, where it is no longer bottlenecked by requiring a person to answer on the other end with all the different trade-offs. I mean, for example, it's not like I'm the first person to diagnose a patient with hyperthyroidism and make that referral. If we could look through the last 1,000 times that happens, shouldn't we be able to automatically collate that information to suggest relevant diagnostics, tests, and medications that technically I could just do right now? But nobody, as a primary care doctor, essentially, I could take care of all those things. I guess though then you can argue, why don't I just do those things? You know, why don't I just read my textbooks a little bit more and I can just take care of all these problems without having to get additional expertise, expert input? That's perhaps technically true. And 100 years ago, you know, one person could know it all and do it all because there basically wasn't that much we could actually do in medicine. Amazing advances in medical science are fantastic, but here there's a little joke article. This guy is weighing the Index Medicus many years ago, the precursor to PubMed. He does this again years later, and he laments the exponential growth in the weight of medical knowledge. And when there are more than 75 randomized control trials and 11 systematic reviews being published every single day, and I don't know about the rest of y'all, but I'm way behind in terms of keeping up with the literature. We are well past the point where the complexity of modern medicine exceeds the capacity of the unaided expert mind. So I've been looking for what are some other additional approaches that we might be able to take advantage in. Well, consider market basket analysis. This is something I've been taking advantage of. Recommender systems, internet search engines, what are they doing? You know, when you go to the grocery store and they're keeping track of what you're buying on a club card, why are they doing that? It's so that then Amazon can recommend you products, YouTube can recommend videos. Why is it that these algorithms, they seem to know what we want even before we've even asked, sometimes frighteningly so. And it's all just based on historical behavior. There's actually a huge amount of information that is historically thrown away and that we weren't taking advantage of before, but which now becomes possible in a digital healthcare ecosystem. So to make it more concrete, I tried bringing this type of concept to inpatient hospital medical decision-making. So for example, a patient gets admitted to Stanford Hospital for a GI bleed, they're vomiting blood. What should you do? Well, these are the clinical orders, the concrete decisions the doctor has to make. What medications, what lab tests do you need, what imaging do you need? And they're sorted by the ones that are disproportionately likely to happen within the next 24 hours based on what other doctors have done in similar situations. So for example, at top, pantoprazole, an antacid infusion makes sense. You're trying to suppress the source of the bleed. Baseline prevalence, only 2% of anybody in the hospital would get that. It's pretty unlikely. But if positive predictive value, given that you're showing up for a GI bleed, 44% of such patients are getting that. That's 50 times the odds. Tiny, tiny p-value suggests there's something very strongly associated about that order recommendation, basically, with that clinical situation, as well as other things, consult gastroenterology to try to fix the problem, a bowel prep to try to flush out your colon, upper GI endoscopy, again, to fix things, transfuse some red blood cells, all things that make sense. Realizing that I never sat down and tried to design a checklist, an order set template. I didn't review the textbooks on what the appropriate things are to do for a GI bleed. This is all stuff that just naturally, organically comes out of looking at the historical data that now becomes possible in an electronic digital healthcare infrastructure. I'll refer you to, for more details, I've written a series of research papers diving into more what the potential of this here, but also realize, look, I don't expect computers to ever stand in for a human clinician. I also don't really expect computers to ever really do the thinking for us. But what these types of data-driven technical approaches can be very good at is managing extremely complex and massive information sources, right? When you do a search on the internet or you get a product recommendation, what that's doing is it's managing, when you have this incomprehensible ocean of possibilities, of possible choices to consider, but you digest it down to a top 10 list. Now that's something a good human can interpret and engage and apply in their individual situation, rather than considering the massive amount of possibilities. In one hospital, one clinic, technically there are tens of thousands of different medications, tests, and diagnoses I can choose for every patient, but that's pretty overwhelming. If you guess at random, you pick them less than 2% of the time correctly. If you use the hospital, they manually curate some standard checklists, some standard processes and guidelines, you would find maybe 35% of what the patient needs. Use these data-driven algorithms based on historical data in a personalized way, and you can recover more than half of what they need, all through an automated process. So I think that's a lot of exciting potential, but if you're thinking it through, you should appropriately pause and say, wait a second. hey, when an internet company recommends you a product, or Facebook recommends you look at an article, they just want you to buy more stuff, basically. They're not really interested if you're better off. Are we learning from the wisdom of the crowd, or do we need to fear the tyranny of the mob? It's actually sometimes hard to tell in the modern world. This is particularly challenging to unravel in medicine because there is no gold standard to define what is good medical decision-making. Again, review my papers for a much deeper dive into this very dense topic. But just to wrap up some of it, eventually, rather than just doing offline statistical analysis, you need to start putting prototypes, you need to putting interfaces in front of human beings and seeing how they interact with it. So we did a study of 43 physicians and put them in front of a bunch of simulated cases in this mock-up interface. It acts like an electronic order system, electronic medical record, and 5 simulated hospital cases. And we told the doctor, just treat the patient, right? Go order whatever medications, whatever tests you think are appropriate, and then we'll see how they do. The distinction here, though, is in addition to all the standard functionality, the system had the option to randomly provide a randomized distribution of the patients were offered computer-driven recommendations powered by those types of statistics and algorithms I described earlier. Based on what's happened to similar patients, this is what we guess you're going to want next, doctor. And then we put that in front of the physicians and saw what they did. Again, for more details, I'll refer you to the paper, but just published literally, 2 weeks ago, a couple key things this study answered for us. Because one common critique, one common question would be, you make this weird algorithmic interface, it was patients or doctors even going to want to use it. Maybe they didn't want to use it, right? Alert fatigue, it becomes very annoying. That's possible and was worth evaluating, but in our evaluation, in our survey, over 90% of them think the tool is very useful and would help their job. And even though it was strictly optional to use, they could have ignored it completely and never interacted with it. They use it in over 95% of cases because it is providing relevant suggestions to them. It is actually anticipating what they need without even having to ask for it, rather than a lot of classical system designs where you have to manually data entry into another website or something like this. We also wondered, wait a minute, you just recommend very common stuff. Maybe doctors become very wasteful. Maybe they'll start making dumb decisions, not going to pay attention. Not what we found. We had a separate expert panel essentially score all of the cases to see the clinical appropriateness of what was being done, and certainly didn't find anything worse happening. In fact, they seemed to do a little bit better, although they also did tend to do a little bit more in figuring out that rough trade-off. Just to wrap up at this phase, and we can follow up in the discussion, ultimately, I think this line of work and all the things that this panel is discussing, I think it all fits into the broader themes of my interests, like how do you crack this iron triangle in healthcare of quality, cost, and access? You cannot improve all three at the same time. They're always fighting against each other, unless, say, we could create supply. We could, say, have automated digital systems. That's one of the few ways you can actually break out of the cycle and make everyone better off. In ways that helps us manage this escalating complexity of medicine that's only becoming more complex, fragmenting care and limiting the quality we can provide. And I think it is these types of innovations in digital healthcare spaces that will allow us to empower our most valuable medical resource, which is people, to make healthcare more scalable and reach responsiveness and reproducibility. Thank you, everyone.
Thank you very much, Professor Jonathan Chen, for your excellent presentation and sharing your knowledge with us about a data-driven healthcare system in future. Thank you. So now we will travel from the United States to Singapore, where Professor Dean Ho is the Provost's Chair Professor of Biomedical Engineering and Pharmacology. And he's also the director of the #1 Institute for Health. And his research interests include personalized medicine and technologies, and development of nanodiamond platforms for drug delivery. And he's also the co-founder of Cayenne Therapeutics. And he's going to share his knowledge with us about harnessing digital medicine to optimize drug development and N-of-1 healthcare. Professor Dean Ho.
Great. Thank you so much for having me here today. It's a privilege to be speaking among such a distinguished group of innovators. And so today I'm going to talk about the use of some of our platforms, particularly for two areas. One is to optimize the design of combination therapies, in particular for SARS-CoV-2, as well as some of our work looking at N-of-1 healthcare. A couple things about our institute. So N1, we are clinical stage. We tailor clinical trial designs to each patient that we recruit, for everything from metabolic disorders all the way to oncology. Wisdom broadens things out a little bit, looking at things like digital therapeutics and the use of other platforms for the rapid design of combination therapies, either for the masses or for the individual. And also a clinical stage institute. And so to kick things off in looking at our drug development work, with the emergence of COVID, and certainly looking at the prevalence of cancer and things like that, drug repurposing has been a widely used approach to rapidly come up with interventions for these conditions. But when we think about applying AI to addressing these conditions, and if we look at this paper, so I published this about 10 months ago, AI for cancer therapy, it's really important to note the different segments that exist in this pathway. When we think about AI for drugs, the most common area that is being explored now is for discovery, right? Using AI for target ID, lead generation, optimization, and beyond. But it's also important to note that even after we come up with a promising compound, even promising agents, when delivered alone at suboptimal dosing, or certainly when delivered in suboptimal combinations, with each drug being given suboptimally in terms of dosing, not only can the results be suboptimal, but they can be completely absent as well, right? Good drugs, wrong dose, no efficacy at all. And so when we look at this next segment of development, these include things like combination therapy design, matching patients to the right trials, and even after this is done, how we administer or dose these therapies will matter quite a bit as well. Now, when we think about combination therapy, particularly for cancer, they're often given at high and fixed dose. And when the patient stops responding, they move to a different regimen. But what we've been able to show is this concept of dynamically dosing patients over time using only their own data to guide that dynamic dosing to sustain treatment optimization. Now, when we think about this workflow here, drug discovery and drug development are often used interchangeably, but in fact, these are very different segments of this pathway that have to be individually addressed, but then seamlessly integrated in order to truly optimize care. So today we'll go over some examples of how we do that. Now, something that we do after we think about interesting drug compounds to push forward into combination therapy design is this AI discovered optimization process, where we use a minimal number of experiments to sufficiently interrogate a biological space. This biological space can be a group of cells, it can be mice, it can be large animal, and it can be patients. And what you're looking at here is an example where this is all human data here, this is in prospective and interventional, where we have leveraged very small amounts of patient data that is prospectively acquired in order to tailor treatment protocols just to these patients alone. And so here's an example here. This is a patient who had prostate cancer, advanced, metastasized to the bone, was on an investigational combination therapy. One drug in phase 2, it was a bet-bromodomain inhibitor, and a second drug was approved. And this patient, the data that we had was the drugs they were being given, as well as the dose modifications that were being done, completely guided based on toxicity. Now, this patient was responding. Their output measurement was PSA level, which correlated very well to the CT scans for this patient. And with just a few dose modification data points, we were able to plot out this quadratic response. We have the saying that we're all parabolas, where biological systems respond in a second order fashion. And with that, you don't need a lot of data to understand how this patient's responding to treatment. So this is a digital representation of a patient response using only their own data. If you take a bird's eye view of this patient's response, our goal here is to drive PSA as low as we can. And if you look at the different doses for the drugs here, our goal is to reach this area here using drug dosing increments that are actually clinically feasible. And what we saw here was for the bet-bromodomain inhibitor, we needed to be giving this patient 24 milligrams in order to get the PSA down to the lowest level possible. The interesting thing is that to hit this dose here, this would be 50% reduction from what they were getting at the time, right? And so imagine going to a clinical oncologist saying, you know what, let's drop the dose of one of the therapies to increase efficacy, right? And so naturally, and let's guide this dose modification based off of efficacy and not toxicity. And so, you know, that was a challenging concept for the team, but the patient at the time was ready to give up on this trial because of substantial toxicity. And so after getting the necessary approvals, we dropped the dose down. Within 1 week, the PSA level was the lowest they'd ever seen during the entire course of the study. With that simple data point, integrated it right back into this profile, which in less than 1 second, the new profile was generated, didn't change much. And it told us to stay low on the dose, and the PSA would drop even more. And so after signing another approval, in fact, a week later, the PSA did drop yet again. And so at this stage, we're well below what the maximum tolerated dose of this drug is. And we eventually started dynamically increasing the dose a little bit, decreasing a little bit. Same with this drug as well, which was enzalutamide. And what was most interesting for the clinical team was that they noted that they're used to giving high and fixed doses of the drug based off of population clinical trials. And in this case, we're using only the patient's own data to dynamically dose their combination chemotherapy. And so with this, what was quite interesting is the patient was able to achieve a completely active lifestyle, halted disease progression, and a durable response. And we've since translated this to additional solid cancer patients and beyond. And what's interesting is now that we're running these N of 1 type trials, prospective and interventional, we can move beyond just efficacy and safety, but we can look at potential cost savings for these patients. For many of these therapies, if you give less drug, the patient pays less. For a very recent patient here in Singapore, we showed that we were saving the patient at least $5,000 a month in cost of care, both with regards to reducing the drug dose over time, reducing complications, and getting a substantial improvement in duration of progression-free survival. We've extended this well beyond oncology. At UCLA, we ran a prospective trial looking at our parabolic driven optimization of immunosuppression dosing for liver transplant patients. In that trial, even though this is not a standard endpoint for the study, but it was first in human at the time, we were discharging our optimized patients approximately 1 month earlier compared to standard of care. And those familiar with the US healthcare system, getting patients out of an ICU a month early represents substantial cost savings, as well as getting an immunosuppressed patient out of a situation where community-acquired infection is an issue. So I'm going to start things off here by looking then at combination design, right? And so if we look at how we optimize combination therapy design with AI-driven approaches, in traditional combo design, you know, we think about different disease pathways and how we can pair inhibitors together, for example, to improve treatment response. And a common question we get is, hey, you know, if I give you a ton of data for patients undergoing different regimens, can you predict for me how the next patient walking in would fare, depending on which regimen we give? So oftentimes, a combination therapy is based off of 2 drugs. In some cases, it's based off of 3 drugs, right? So people say, hey, look, you know, these 3 drugs, can you predict who will respond and who won't? In some cases, there's even 4 drugs, right? And again, this common question we get is, if you take a bunch of data, big data, millions of data points, can you tell us which combination will work best for the next patient walking in the door? What's important to note is that no matter how much data we have that's pre-existing, a lot of these data points are based off of regimens that are given at fixed dose for these patients. We're missing a lot of data with regards to how patients will respond to different permutations of combinations with each drug being given at different doses. That's an entire galaxy of data that's not there. Right, so using pre-existing data, potentially we can make a prediction that a 3-drug combination will work best for the next person walking in. So we do things a bit differently, right? Let's think about dramatically expanding the number of drugs we want to try, right? And when you do that, that substantially increases the parameter space, right? So if you take 12 drugs, 12 is not a big number, but we also know that dosing matters, right? Depending on how you optimize dosing, that can also influence which drugs belong in the combination in the first place, all right? So let's up it to 12 drugs. Even if you look at each drug at 10 doses, that's 1 trillion possible drug combinations. Now let's pretend that drug number 5 has no efficacy on its own, right? And in traditional screening, drug 5 will be kicked out, never really thought of again, right? But we don't do that because it's entirely possible that drug 5, when given correctly with another drug or another 2 drugs in this regimen, with each drug at the right dose, that drug 5 may in fact comprise the top ranked combination out of 1 trillion possible combinations. So we don't use big data, right? We take a small data-based approach, maybe a few hundred data points, which you can prospectively acquire on a dish. And instead of these fixed dose and iterative dosing arrangements, we use multiple drug dose permutations, different iterations of these combinations to sufficiently interrogate this massive space here, right? And so we're effectively using experiments to crowdsource the disease, to populate this space with that data. Then we subject that to our quadratic optimization, which will then give us a ranked list of best drug combo all the way to worst drug combination. And that list is based off of experimental validation, right? And it's entirely possible that at the very end, drugs that are not useful on their own, but when paired with another drug at the right dose for each drug, that in fact may be combination number 1. And so what we've shown is that when we use AI-based approaches to optimize drug development, to optimize N of 1 combination design, it's not about how much data we have, it's about how we actually acquire that data. And in our case, we prospectively acquire that data in order to drive the optimization approach. We don't use pre-existing data sets because we need to broaden the interrogation of that drug dose space. And patients are too variable from each other, and they're too variable from themselves over time to not introduce too much noise if we use millions of pre-existing data points to do this. And so what I just showed you was an example of an in vitro or an ex vivo strategy to optimize combo design. But this is in fact a process that we take all the way through again in vivo and again clinically. It's a re-optimization of, again, picking lead combinations, re-optimizing their dosing and re-optimizing them again at the clinical stage in order to sustain this favorable treatment response. So I'm going to give a quick example before I sign off using COVID as an example. And so around March, we teamed up with an ex-CDC field epidemiologist, with a group of virologists, engineers, et cetera. And we implemented this prospective dose and drug interrogation process against the live coronavirus. And what we did is we picked 12 drugs that were in clinical trials at the time, ranging from remdesivir to favipiravir to ritonavir, lopinavir, et cetera. And what we did was we, again, designed these prospective experiments on the live virus, which then yielded a fair amount of prospectively acquired crowdsourced data from the live virus to tell us what the optimal combination would be against the coronavirus, but also which combinations would not be effective against the coronavirus. And so what we showed, again, using what we call identify for this process, we do not do any in silico modeling, right? We pair prospective experimentation with optimization. We do not use pre-existing data. And again, using this drug set, we were able to look at what combinations were optimal as well as suboptimal. In addition to ranking these combinations out based on efficacy and tox, we also look at the drug interactions that drive this optimization process. And so this is the list of ranked combinations that came out. What we saw was that remdesivir plus Kaletra was the top ranked combination. But what's interesting is that clinically, Kaletra has been shown to be relatively ineffective. And we see that as well, right? Kaletra in our study here basically showed that it was useless, right? It was not useful. Remdesivir alone was pretty good. And as we know, remdesivir is not a magic bullet. But when you take this relatively ineffective drug combo here with Kaletra, you combine it with a moderately okay monotherapy, you get substantial increase in efficacy, reaching basically complete inhibition. And we showed it was the lopinavir-remdesivir interaction that drove that. And we know that ritonavir and lopinavir interact well. And so this effectively turbocharged this interaction even more, right? So this regimen here outperformed remdesivir monotherapy alone by quite a bit, dramatically outperformed Kaletra, dramatically outperformed hydroxychloroquine, azithromycin. But what this shows, again, is that this relatively ineffective combo, when co-delivered with something else at the right clinically relevant dose together, we can make a lot more out of traditional repurposing, right? When we think about repurposing, it's a lot more than just finding a drug candidate. It's about ensuring that we co-deliver that candidate with the other right candidates, with each asset being given at the right dose. Right, and that represents an insurmountable parameter space, right? Again, this is all prospective data, and this entire experiment was completed within 2 weeks. At the end, our goal here is to provide the clinical community with ranked combinations that they should potentially be looking at to give patients, but also combinations that can probably be avoided. And so the next step for this Identify platform is we have multiple approved clinical protocols to use this as a first-line clinical decision support platform for emerging pathogens in the future. And we also have some approved protocols for various combinations that reside within this optimization approach. And so final thing I'm going to talk about, again, the core ethos of our institutes is that technology alone cannot change healthcare. We have a group of healthcare economists, behavioral scientists, clinical trial design innovators, and beyond as a part of our institutes. And so we teamed up to do something fun. We developed a comic book. We actually started this comic book 2 years ago. This is Aiden and Eileen versus Vinny the virus. It's available for free download at our institute website. And this is really a fun project for our PIs, our students, our researchers, et cetera, to come together to develop. It's available at the libraries in Singapore, and we've had friends and colleagues download this from around the world, not only for the early learners, but for a number of people who want to learn more about how AI can help with healthcare. With that, I wanted to thank all the individuals that make this work happen. Amazing group of clinical collaborators, global collaborators, as well as my own team, and we're deeply grateful to the funding agencies that support our work. Thank you very much.
That was fantastic. Thank you, Professor Dean Ho. I was thoroughly engrossed in that, and dynamic dosing using our own data. I love it. So that's now time to move into our panel discussion and think about some of these brilliant questions that have been coming in along the way. And so I'm going to hand over to Esther to get us started with the panel.
Well, thanks to all the wise keynote speakers that we heard. Before we start the panel discussion, I'd like to give a brief reflection on what we've heard today. We heard a lot about the importance of digital health and data-driven healthcare, especially in a COVID pandemic. Necessity is the motor for innovations. That's what we've learned today. And pandemics stimulate improvements in healthcare and in society. We heard about the rapid vaccine development, about remote healthcare adoption that has increased tremendously. We heard about AI prediction of disease and the safeguards that are needed, and also about the impact of social media with good and bad examples. We learned about mHealth for COVID-19, that may be better than the general practitioner for tracking symptoms of COVID, even diagnosis through audio data, and severity of COVID via speech and symptoms via heart rate. We've learned that telehealth is not new at all. For 2 decades, it's already part of healthcare, but since the pandemic, there has been a massive increase in the use of telehealth for children, adults, elderly, in all specialties of healthcare. And it also had a key role for COVID-19. The challenge is to make it sustainable and to have more scientific evidence. We heard about clinical decision support with data. We learned about prediction of patterns of disease. And in future, we will have a data-driven system that will help doctors and patients. And finally, we learned about drug development with artificial intelligence, personalized therapy with personalized data, also with an optimal combination of medication for several diseases. So thank you all for sharing your knowledge. We've had a lot of intelligent questions, and we have we're a little bit short in time, Michelle. So we had prepared some questions for the keynote speakers with the organizing committee. But since we've had so many fascinating questions from our delegates and our participants, Michelle, could you choose a question that has not been answered? Because I already saw that some of the keynote speakers have already answered the questions of the delegates. Maybe you can choose, Michelle, a question to start with for our panelists.
Oh, that's pressure. We've got some really excellent questions. I'm going to start with one from the first talk, actually, which from Dr. Ashley McKimm. So we gave us an overview of the 5 barriers. Can you tell us, can we expect the 5 barriers to digital health that you mentioned to come back again once COVID is over?
I was slightly fearful you were going to ask me that, Michelle.
I think
I think there's a reason we've had barriers in healthcare. In the past, if you look at some of the barriers, they're there for good reason. We have regulation in place to make sure that patients are safe. We have a risk aversion because a lot of technologies aren't proven. We haven't got the evidence. We want to check they're safe or not. And there is also that fear of that new technologies will create a barrier between the patient and the doctor, and they'll slow our day-to-day jobs down as well. I think what happened during COVID is we had a flux in that process that we were able to push the boundaries of where the barriers were. I think it's only right that some of this come back. So I think a lot of things that we did during COVID are probably things that we'd want to evaluate. We'd want to check whether they're effective and safe. We'd want to do that proper evaluation. So I think it's good that they come back a little bit, but I'm hoping that the COVID situation has shifted them a little bit further. And we've heard about lots of really exciting things from AI and telehealth from the other speakers as well. And I think we have moved a big jump. Things like vaccines have made a huge jump, but I think it's only right we come back. So I think we don't want to get rid of those barriers. I think we want to work with those barriers to try and progress things. And I think we will see some of them come back, but it shouldn't, I think, hold us back from doing future innovation.
Brilliant, thank you. Very comprehensive answer there. And then another one from your talk, which hopefully is a slightly quicker one, but a really important question. So how cheap are digital tools, and can Africa, the example here, actually afford that? And was there a high penetration in the pandemic? So kind of feeding into that inequalities point that you were making.
So I think it's difficult to sort of generalize that, whenever you talk, AI can be, and digital tools can mean anything. COVID's really changed just the fact that we're all here from all over the world joining remotely. Whenever, if this event took place in Hong Kong, most of us couldn't travel there. And we're seeing the same. We had an event this week that we usually have people from 80 countries, but very few people from Africa, very few people from low-income countries. But the fact that they didn't have to pay a big fee, didn't have to travel, could join virtually in their free time, meant that we had access to, they had access to the top speakers, the top experts that they never had access to before. Similarly, there's lots of content that's for those countries that we can use digital technology to deliver more cheaply, more effectively. And I don't think we should rule out very cheap technology. SMS technology's got fantastic potential for impact in Africa as well. So I don't think it has to be expensive. I think we automatically assume it's expensive, but I think more so countries like ourselves who are, high-income countries, we should be looking at some of those innovations, some of those frugal ideas, and bringing them back to our healthcare systems as well.
Brilliant. Yeah, I agree. That's a really important message, that things don't necessarily have to be expensive in this space. So, yeah, really good point there. Esther, are there any questions that you spotted that you really want to share?
Yes, I'd like to ask some questions to any keynote speaker who would like to react on this one. We are in the middle of a massive health system transformation right now because of the COVID pandemic. And what do you think, how can ISDH and all your own academic organizations contribute to this transformation period via research and evaluation and via evidence-informed policy translation? How do you look at that? How should we take our role?
I was just going to jump in really quickly to say that certainly during COVID, but before COVID, one of the major drivers of our ability to look at things like advancing N-of-1 medicine and dynamic dosing and rapid combo design into the clinic has been excellent engagement with the regulatory system. The accessibility of our regulatory system here in Singapore has been remarkable, and as we've shown, has actually led to life-saving outcomes because of not only certainly rigorous, but also rapid clearance for certain trials to start, but also working closely with tech developers to innovate how clinical trials are designed. One really quick example, if you look at traditional drug development, when a drug's going through trials, patients will often be randomized to different dosing cohorts. Someone will get a high dose, middle dose, low dose. And if a patient in the high dose cohort doesn't respond, they'll often be removed from the trial, right? A non-responder. We'll never have known if the patient would have responded to a middle dose or a low dose. And as we've shown time and time again in clinic, especially in combination therapy, we have patients that don't respond at all to high dose treatment, and they would have normally just been moved to another line, reducing an option. And what we've shown is that by scanning this dosing regime, we can actually drop their dose and again, not only get a response, but get a remarkable response from these patients. And then we start changing the dose over time as we start rolling in their prospective small data sets. And it's really a remarkable interaction with our regulators that allows for these first-in-kind trials to move forward and to lead to strong patient outcomes.
Thank you, Professor Dino. I saw that Professor Anthony Smith wanted to react as well.
Our responsibility in sharing information is key, and from a journal perspective, Journal of Telemedicine, Telecare is obviously one of many excellent journals around the world who are taking that responsibility on board. You know, we heard from Ashley with a massive boost in the number of papers that are coming into BMJ Innovations. You know, the same experience we're feeling with the JTT. The other positive thing is we're starting to see more evidence-related papers appear in the non-telemedicine journals, primarily the clinical journals. And I think that's a very important development for digital health and telehealth generally from a global perspective. And I would encourage, you know, journals to kind of take on these papers. One is because it opens up readership. It gets into the hands of the clinicians who will best benefit from that. And I say that as a fair contradiction because I encourage clinicians to read our own journal, but I do appreciate the fact that there are medical, nursing and allied health journals out there that should be publishing this as well. I think in line of the evidence, and I do agree that the evidence is very important, I think we have to be cognizant that there is a lot of evidence for a very broad range of digital health applications out there. Our stumbling block tends to be how do we actually adopt that in routine practice? And my point of my presentation was about trying to make sure we prepare our workforce and have the right systems in place. And from what I've seen in the last 2 decades, it's not whether or not you can find a technology that will do a good job and provide an excellent service. It's how can you change the way a doctor or a nurse works, and how do you kind of change in a longer term basis, in a permanent basis. So I think working with the workforce, redesigning models of care and making sure our workforce is educated. But this presentation and this conference, for example, is a good medium. And to answer your question, Esther, I think any avenue to share information and share experience, you know, with, you know, either the speakers today or members of the audience is a very positive move. And I think that's only going to get better in time.
Yeah, thank you very much. Jonathan Chen, I saw that you reacted also via the chat. Maybe you can share that verbally with us as well.
Sure. I was just saying, well, having a pandemic, there's this phrase, never waste a good crisis in some sense. And this has certainly been a burning platform to motivate rapid change that I'm sure Professor Smith can comment. It feels like years of telehealth innovation implementation happened within weeks. I think our hospital was just playing with like one clinic having televisits, and then like 1 week later, it's like, okay, every hospital bed had access to an iPad that didn't exist there, 1 week before. It was how motivated that happened. I think it was very cool to see like the pragmatic adaptive trials like Recovery really showed what the power of that was. That technology, that concept existed before, but here the rapidity with which you could study many different possibilities, I thought was very cool. But I think the question was more like, what's the role of like academic institutions here? I think a good thing to break down is the appetite for answers was clearly much hungrier than like the evidence could keep up with. And so everyone's just glomming onto whatever they see on some random social media feed. And so clearly we also need to be the stewards to ensure the evaluation is happening, ensure there's rigor in what comes out. And also part of why I feel our job is to scientific communication with the public too. It's easy to just point at people and say you're wrong, but it's like, well, okay, but can you talk to regular people and get them on board?
Thank you, thank you. Question also for Björn Schuller. You have shared a best practice with us, something you developed for yourself and is also being evaluated in the academic world. How would you define good and bad practices and how important are they for the evaluation of telehealth?
I'm not sure if I get it 100% right, but anyhow, I wanted to comment on the previous question. Maybe this goes together. So we have been all working under a lot of pressure, time pressure these days to put results out there immediately. We have changed our working patterns tremendously, not flying, all of a sudden having a lot of time to write. But it's also time now to, I think, to make the best of the past and the future, the past and the present situation. So in the past, we had very rigorous peer review. Now we're almost beyond peer review. Everything is put onto archive immediately. Everything is picked up by the press immediately. We have to de-accelerate that, but keep the momentum somehow of being fast. Now, so in terms of best practice, I'm not sure if you meant for evaluation, or what did you mean?
Well, the question is more like when you look at the healthcare transformation that is going on right now because of the COVID pandemic, we have to scale up in a constructive way. And how important do you think it is to share also good practices in order to do it in a constructive way?
Yeah, it is, of course, very important, but sharing it with a certainty and not too rushed is the best way, I guess. Scaling up is a different problem anyhow for many of the solutions we are providing. And there we have to be careful that we're not doing something too rushed too, of course.
Okay, thank you. Michelle, do you have one final question for one of our keynote speakers?
Yeah, I think this one combines quite a few that were in the chat in response to a number of different talks, actually. So how do we find a balance between the clinical safety versus, you know, the real promise and innovation and speed that comes with AI? And, you know, how can we learn to trust those AI models? So, you know, any of our panelists, you're welcome to respond to that one.
Yeah, maybe just a quick statement on the trust. Trust is best established, of course, by providing something that works and that is actually delivering a benefit. Apart from that, of course, we have to make sure that it's explainable. This is what we're mainly working at the moment. I think that was also one of the questions in the chat. Was all the deep learning, do we still know what we're doing, or is it just working and we don't know why? So this is a major construction side for us these days, of course, to make sure that trust comes from it works, but we know also why it does. Yeah, that's it.
Of course, I would agree with that. I'll offer a controversial take just for some controversy. Why do you trust your doctor? Why do you trust the medical textbook? Do you think they're always right? Because I guarantee you they are not. So what kind of standard are we holding to what? If we only did things that we were absolutely sure would make a patient better, we pretty much do nothing. But I would like to think we guess right more often than we're wrong. That's why you allow us to practice medicine, basically. And so could such tools help us do that in a better chance? I think so. But nonetheless, let's follow it up with evaluation and not be chasing things that are, you know, a lot of snake oil is naturally what gets sold in medicine all the time.
Well, yeah, that's a controversial, but I like that response. Anybody else want to add anything there before we wrap up?
So now we're going to wrap up. In my country, it's middle of the night now. Some people have a busy day ahead. So we're going to end this first excellent session, but not before we announce the second session, which is in about 6 hours, like now 5 hours, Michelle. It's in 5 hours with the program with another set of excellent keynote speakers, which you can see here on the slide. Steve Davis, Professor Kendall Ho, Professor Joseph Carr, Professor Tomohiko Moriyama, and Professor Homero Rivas. So please join us again in about 5 hours. I'd like to thank all the excellent keynote speakers today for giving very insightful presentations. I'd like to thank all the participants for watching the presentations and participating. Thank you very much. And of course, last but not least, the organizing committee of the Chinese University of Hong Kong. Thank you very much for hosting this session. And well, see you all in 5 hours. Bye-bye.
See you.
Thanks, everyone. Bye.